Hello everyone, and welcome to today's webinar on the ripple effect, Northwell Health's journey to faculty training and development. Thank you for joining. This webinar is hosted by the Academy of Communication and Healthcare. My name is Rachel Porch, and I'm the project coordinator here at the Academy. ACH is a nationally based nonprofit organization, and this webinar is part of a special webinar series from ACH, where communication training program leads from institutions share their journey in implementing a skills training program at their home institutions. If you're not an ACH member and would like to benefit from our many benefits, such as our recorded webinars, online member community, as well as many other valuable benefits, we'd like to invite you to join our organization. Feel free to visit our website for more information. The link is there at the bottom of the screen. A quick housekeeping note before we get started. Our participants are welcome to use the chat feature, which you can enable in the webinar settings on your screen. We'll be holding all questions for the end, but if any questions come up throughout the presentation that you don't want to forget, feel free to type them there in the chat box, and we'll address all questions at the end, time permitting. So moving forward, I'm pleased to begin my handover here to the Northwell Health team. We'll have Dr. Jill Kalman, Dr. Ellen Perlman, and Ms. Aggie Barden with us today. Welcome and thank you.
Thank you, Rachel. And good afternoon, everyone, and welcome to our webinar, The Ripple Effect, Our Journey to Faculty Training and Development. We're really honored to be here with you this afternoon. And I am Aggie Barden. I'm the Vice President in the Office of Patient and Customer Experience at Northwell Health. And I'm joined with my colleagues, Dr. Jill Kalman, who's the Executive Director at Lenox Hill Hospital, and also the Medical Director for the Northwell Health System Patient Experience. We also have Dr. Ellen Perlman, who is Associate Dean for Advanced Clinical Learning at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell, and also a Fellow in the Academy of Communication and Healthcare. And we are thrilled to be with you today to share our story. So our objectives are as follows. We're going to explain the impact of providing faculty dedicated time to learn, practice, and hone facilitation skills in a safe and supportive train-the-trainer environment. We will verbalize the Northwell Health barriers, strategy, sustainment, and lessons learned of the relationship-centered communication program. And we'll state the impact of the train-the-trainer program on faculty development, course evaluations, patient experience outcomes, and research findings. So let's start by meeting Northwell Health. So Northwell Health is a large integrated health system in New York, ranging from Westchester County, going through New York City and all across Long Island. We have 23 hospitals, over 600 medical practices, a medical school, an advanced nursing and physician assistant program, research institute, and a large community health imprint. We are New York State's largest private employer, caring for 10.8 million New Yorkers per year. But our greatest assets are our people. We employ over 63,000 employees, in which approximately 4,000 are physicians. In addition, at Northwell, we really focus on 6 main pillars, focusing on our clinical care delivery across a full continuum of care for our patients and families. We have a large educational imprint with one of the largest academic teaching institutions. We have a research institute, and we're a leader in pioneering discoveries and innovations for patients and families. We also have a huge focus on population health, positioning for value-driven care, and a focus on community health and committed to all of our communities, which are diverse and across a large geographic span. And we also have a venture arm that looks at new businesses, consulting and partnerships, and creating margin for our mission. As mentioned, we have a partnership with our Donald and Barbara Zucker School of Medicine at Hofstra Health. The school opened in 2011, and putting the patient first is the organizing principle of the school. 4 classes of physicians have graduated. The mission of the school is in a culture of community, scholarship, and innovation dedicated to inspiring diverse, promising students to lead and transform medicine for the betterment of humanity. And the School of Medicine takes a truly innovative approach to immersive learning, having real-life experiences from the very first day they enter the school. The curriculum is grounded in humanistic communication, and it's weaved throughout the entire program. So at Northwell, we have three main promises that we hope to deliver to our patients, to our community, and to each other. Our first is our brand promise, which is our promise to our consumers. Our second is our employee promise, which is a promise to each other. And our third promise is our culture of care, which is our promise to our patients and families. We focus on providing world-class service and patient-centered care, grounded in our values of truly being compassionate. Our definition for patient experience at Northwell Health is every moment matters. Our strategy for patient experience is focused on four main pillars: culture, care delivery, hospitality, and of course, all grounded in accountability. And these pillars align with the Barrel Institute's findings for patient and family-centered care. So our first stop is our culture of care, which is our 2-hour interactive patient experience framework that was established in 2015, and it was delivered to 65,000 employees across Northwell Health. All employees, when onboarded as new staff members, receive the 2-hour Culture of Care course. It's an interactive course based on four main pillars of connectedness, awareness, respect, and empathy. And now I'm going to pass it over to Dr. Jill Cowman, who will continue our story.
Thank you very much, Aggie. So as Aggie said, we started with our culture of care as our foundation. And this, interestingly, was taught as a complete multidisciplinary group, including doctors, other clinicians, and non-clinicians. And as Aggie said, we educated over 60,000 employees. But we always knew we wanted to create a course that was a specific communication course for physicians. And so we knew the timing was right to implement a specific course. This course has been a true collaboration. The vision was developed by our Chief Experience Officer, myself, and other physician and clinical leaders. And what the vision was to bring an experiential program, interactive, participant, but grounded in humanism and evidence-based practice to the organization. We also knew we wanted to collaborate with our medical school, with the Donald and Barbara Zucker School of Medicine at Hofstra Northwell, where Dr. Ellen Perlman, who you hear from afterward, oversees the communication program for our medical students. And since these students are our future workforce, we wanted to make sure we could align from the very beginning what they were being taught with what our providers were utilizing as communication skills in the hospitals and in our practices. And then we decided to collaborate with the Academy of Communication in Healthcare, ACH. Now, we had looked at several organizations and truthfully decided that the best partner was going to be the Academy of Communication in Healthcare. One of the reasons is that we knew it was going to be a true collaboration, and it is. We were able to develop a curriculum that was flexible, that was able to put in some of our core elements of foundation as well as communication, and that it wasn't a product that was clearly just developed by them. So it was a true meshing of both of our programs. So that was our decision to partner with the ACH. We then needed to select the right initial faculty for this really first course that our physicians had not gone through yet, and it was extremely important to think about. What we really wanted for our first group of faculty, which was 13 facilitators, was to choose leaders across the health system, diverse roles, and geographically span our health system since we are so large. So in terms of leaders, we chose medical directors, chairs of departments, executive directors, and then we choose different specialties of emergency medicine, hospitalists, anesthesiology, surgeons. And with that, we compiled a very diverse list, and this was okayed and really vetted fully by the Chief Medical Officer of our system. And with that, I'm going to turn it over to Ellen.
So as you've heard, I am both an Associate Dean at the School of Medicine affiliated with Northwell, as well as a faculty and fellow for the ACH. And I had come into this project as the senior trainer, having done several train the trainers at other institutions. And so I was really delighted to be able to bring this experience to my home institution. And I was really excited about the Northwell's decision to start with a group of trainers that had leadership roles across the system. And what I really thought was amazing about this was that not only were they committed to funding a train-the-trainer program, but they were putting some of their busiest clinicians in the role of having to train. And the whole group had enormous buy-in into the project and a commitment that not only were they going to have to attend trainings, but they were going to have to practice a set of new skills. Nevertheless, I was quite apprehensive as well. One, knowing that I had some personal relationships with them. Second, that as you know, people in leadership tend to be rather outspoken and to have strong opinions. Third, that just because they were skilled at leadership did not necessarily translate to being skilled at doctor-patient communication. And then finally, that we were talking about a group of people who had on the order of 20, 30, 40 years of clinical practice under their belt. And were they really going to be able and amenable to learning new skills in order to teach them? And in fact, the first day of training really brought all my fears to light. To say that this was an unmitigated disaster is really not an understatement. You know, traditionally, the first day of training, the future trainers are the participants in our one-day workshop, and they did not like our workshop. About when it finished, half of them were on the phone with Aggie, the other half were on the phone with Jill. A few of them were curbsiding me. We can't give this content. I can't buy into this. I can't get up in front of people and tell them to do this. And you can see by the faces in this picture, that pretty much sums it up. And so, you know, Aggie, Jill, and my co-trainer, Kathy Risden, looked at each other and said, well, what can we do? And we said, well, the only thing we really know how to do is use our relationship-centered communication skills. And so that's what we did. On our second day of training, we got everyone together and in kind of an elaborate creative structure, listened, empathized, tried to be what I describe as radically non-defensive. We collaborated on a shared vision. We were able to explore barriers. And finally, we're able to come to agreement about a product that we all felt comfortable putting forward. And I think that this is a really key point. And, you know, again, my personal plug, of course, entirely biased for the ACH, but it really, ACH is an institution that allows each institution to put its own stamp on the curriculum that's developed and given. And so we decided to do something different than had been traditionally done in ACH Train the Trainers, which was to align our school, our curriculum with the medical school, which uses a very particular approach to teaching communication skills, which is the three-function model of the medical interview, which was created by Stephen Cole and Julian Bird. And this model is very different from teaching communication in the usual way to new learners. You know, traditionally, we all learned the structural approach to the medical interview, where you go in, you take the chief complaint, you do the HPI, you do the past medical history, past surgical, et cetera. And instead of teaching that, we teach that there are three functions to the medical interview. The first is to build the relationship with the patient. The second is to assess and understand the problem or the problems. And the third is to collaborate with the patient around the plan. And what I really like about the use of this model is that it's particularly helpful when you're working with people who are advanced in their career and advanced practitioners, because this is intuitively what people start to do is they don't follow the structure anymore. They find themselves gathering information at the same time they're providing education, And of course, we all intuitively like this. So just to say that part of building the relationship, the skill set that we teach in Function 1 is empathy. And there are many different models of teaching empathy out there. Again, we went with the one that's in line with what we teach at the medical school, which is that empathy has 3 micro skills: reflection, legitimation, and exploration. And we did, again, something a little bit different than traditionally is done in ACH training, which is that we put this front and center. We started the day with empathy, and we started it with empathy for each other. And so the participants are given the opportunity to practice using empathy with each other. And I think that this really, more than other trainings that I've been a part of, has really reduced the resistance of participants in the room to lead with empathy. It also really allows people to reconnect with the reason that they decided to become physicians in the first place. So, you know, I think it's really important. One thing that is always done in Train the Trainers is to have a graduation ceremony. And I think this is really critical because it really is a transformative experience for the faculty who become trainers. I think that what happens is that they learn the relationship-centered skills and practice them. They realize that they are applicable across a variety of settings. So our trainers definitely came together and said, you know, I'm using this at home, and I'm having a much better time, you know, getting along with my spouse, or, you know, I managed to get my teenager to actually talk to me. And this is, you know, commonly the experience. And this was true in our Cohort 1. It's also a really special opportunity for people of different disciplines to work together and to meet like-minded individuals. And I think for most trainers, it allows them to, again, have a renewed sense of energy and purpose around what they do. And so I think the graduation is an opportunity to really highlight all of those accomplishments. So we, when we first started rolling out our one-day workshops, the leadership here did a couple of really important things. The first is that, you know, in addition to them actually being leaders at a number of meetings, they each took it upon themselves to really be spokespeople for the upcoming workshop. Jill managed to make presentations at some really key meetings. We had testimonials done by the medical director at the North Shore Hospital talking about how it had transformed him. And so there was a lot of excitement and energy drummed up around the upcoming and impending workshops. And then all of the facilitators really took it upon themselves to recruit the leadership around them to make sure that they took the course first, and so that they could spread the word. And second, the second really important thing they did was to make it voluntary. They did not mandate that people attend. And I think that this is crucially important, that people early on have a really positive experience, don't feel like they're forced into something. And we really focused on the frontline practitioners in the hospital, ED doctors, hospitalists, cardiologists, obstetricians, pediatricians. And year to date, we've had over, I think this number is even higher now, over 650 providers who have completed the course. And again, compared to other trainings that I've seen, there has really been a minimum of resistance among participants, and I think it's because of the careful way that this was rolled out. So naturally, when you recruit your first set of trainers to be high-level leaders, they don't have time, ultimately, to commit to the growing number of workshops that need to be accomplished. And so we had to, in pretty quick order, had to get a second cohort involved. And I like to say that the second cohort of trainings is a lot like your second child. You know, when you have your second child, you're like, why was I in such a fuss about the first child? This is, you know, just a baby. They're so much easier than the toddler. And that is definitely true of second cohorts. They've been handpicked by the first cohort for their behavior during the workshop. And so we picked people who were particularly enthusiastic and actually had great aptitude for the skills. And just like it's important for second children to have their pictures taken and put in photo books so to document their existence, I think it's also important to celebrate the second cohort also with a graduation. And it's also important to make sure the two cohorts meet, get to know each other, because after all, they are going to be working together and have to develop a new sense of a cohesive group. With that, I'll turn it over to Jill to talk about the impact.
And with that, we have seen enormous impact on both the facilitators and as well as those we've educated. And before you see several quotes, but I will really just say that the facilitators, when we started utilizing the skills that we learned in facilitation with our patients, we had incredible aha moments on how this changed the interaction and the relationship with our patients. And these are clinicians that have really been doing this for years. So it's truly transformational, and things that people who've been practicing for a very long time have made changes and have changed the trajectory of probably of the clinical course of patients because of it. And with that, we made a testimonial video because we had so many people who wanted to speak about it, and this is a condensed version.
Proper communication is really the heart of our relationship to our patients, understanding their disease, understanding the impact of our intervention. And I don't think it can be separated from good medical care, and that's what we do at Northwell.
The quality and nature of the physician-patient-family relationship is paramount to the quality of care that that patient receives.
And I think at this point, Northwell has demonstrated a pervasive commitment to the compassionate, caring, culturally sensitive, artistic implementation and application of the vast amounts of scientific knowledge at our disposal.
We can all do a better job of bringing empathy to our work, to our patients.
Is that we are going beyond patient-centric care to relationship-centered care, and that our relationships with our patients is a true partnership and collaboration that we plan on continuing throughout the lifespan of our patients. And that's the difference at Northwell.
And one of our challenges everybody spoke to us about was how are you going to gain traction with sustainment of the skills that are taught in a one-day course? And so we really looked around the country as what were some of the best practices for sustainment. And we landed on something called communities of learning and practice. And we have now enacted this at several of our hospitals. And what we do is every month or every other month in a luncheon setting, we bring any participants in each of the hospitals together with facilitators, either the medical director, the patient experience director, and any facilitator at the present site. And we have a community of learning that goes over the core concepts. We review how they're using it, limitations to using it, ways they're using it. We then review one of the core concepts, and then we talk about tough cases and how the communication may have changed it. And it's been extremely successful and gratifying. We've also had success in our communication domains. This is 2016, 17, and 18 from dark blue on the left to the right. We started in the middle, June of 2017, and even with just 6 months of data, we saw increases in each of the domains of communication. And in 2018, year to date, this is also July, we've also had, again, a consistent increase in the communication scores for physicians. And of all the domains, physician communication is the greatest increase in our HCAP scores, and it really is consistent with starting the course. And back to Aggie.
Okay. So right at the very beginning, we knew that we wanted to really include research in this work. So our very first study was an impact of Train the Trainer course in relationship-centered communication skills on facilitators. And what we found was that our intervention of Train the Trainer had statistically significant findings in total performance. So we also looked at the interreliability, again with positive results, and we submitted work on this and our manuscript, and we're awaiting publication on this work. Our second study is the impact of communication skills on physician burnout and patient-centeredness, and this is currently ongoing. We began collecting data last November, and we're exploring the impact of the variables of burnout, patient-centeredness, and patient engagement. We surveyed the participants 1 week prior to the course, 1 week following the course, and then 3 months later for following the course. And we're looking forward to seeing those results within the next few months. So looking ahead, we have now decided that we're going to do ongoing faculty development, and we're actually going to begin our 3rd cohort in January of 2019, and we're continuing RCC education and sustainment. And just in recapping our story, you can see we actually began in 2014, the partnership in 2016, our first cohort in 17, our graduations, and then our 2nd cohort in 2018. And what I'd like to introduce is, if you look in June of 2018, we began our residence throughout our organization. And also we began working in August of this past year, work with our ACPs, our nurse practitioners, and our physician's assistants, which are really getting great traction. So our courses are now interdisciplinary across the organization, where we can have residents, NPs, physicians, PAs, and we're getting really incredible feedback on this. And as we said earlier, we're hoping to begin our 3rd cohort in January 2019. So we want to thank you, and at this point, if we have time for questions, we'd love to entertain them. Hello?
Thank you all for a great session. Again, we'll just give everybody a moment here to type in some questions if they have some. Those on the line, you are welcome to use the chat box for questions. Again, that should be located on the settings on your screen. And
so the first question I see on the screen is, do the residents take the course together with the attendings? And the answer to that is yes. And it's been a great combination. I think there's a lot of respect going both ways, and the interesting thing is that the residents are closer to medical school. A lot of them have been taught this already, so they're actually they're very easily accepting of the course. But it's a wonderful combination.
I also think, this is Ellen speaking, having watched many train the trainers, that the attendings who are a little resistant behave much better when there are residents around. So it's also been that added benefit.
I totally agree. And there's another question: is there any involvement of frontline staff? And the nurses in our health system are going through a communication course as well. But I would say, in terms of frontline staff, if you mean, we have certainly our frontline providers, hospitalists, ED physicians, and now mid-level providers. So
but not office staff.
But not
we do not have
non-clinicians, right? Non-clinicians.
What we offer for our office staff area is our culture of care course, which is specific on the 4 principles of connectedness, awareness, respect, and empathy.
The residents mandated or voluntary, it's still voluntary for everybody, but we're trying to be prescriptive as we go through departments with the administrators to have their residents sign up.
And there was a question about that.
One day
I'm sorry.
Sufficient follow-up. Can we answer that last question? 1 day training?
Yes, please.
I mean, we think that there has to be follow-up, and that's our sustainment is in the communities of learning. Another thing we're thinking about is a subsequent to the course, a just-in-time training, coaching, shadowing of the skills, so you can get just-in-time comment on the way that you're utilizing the skills.
Yeah, and we're beginning to work on that particular piece for next steps.
And it looks like there's some questions here regarding the measurements that you all are using, and like how you're measuring the effects of the program, and what assessment tools.
Yeah, so the first part of Train the Trainer program, we've used an OSTI type method for our model. So all individuals, the OSTI is the Objective Structured Teaching Examination, and they did a pre and post in terms of their ability to teach the course. We also involved our 4th-year medical students who were in the role of the learner for that. And that's what we did for the first one. And for our second one, as we mentioned, we're looking at those variables of burnout, patient-centeredness, physician engagement. And we can also tailor that to their patient experience scores at their specific site.
And you use validated tools for patient-centeredness and
yes,
and
all the
physician
tools
engagement.
are reliable and valid, yes.
But in terms of the effectiveness of the workshop per se, it's all been through press gaining scores, correct? Or HCAPs? HCAPs.
Mm-hmm.
There's a question about do they receive CMEs, and actually everybody who takes the course receives CME and MOC when it's appropriate.
And now CEUs for our nurse practitioners as well, and we've also been able to work with our PAs for their accreditation as well.
That is great. We are now at time. Thank you again for such a great and informative webinar. And thank you everybody who has joined and participated in asking questions. This webinar was recorded and you will receive the recording and some post-webinar follow-up information shortly.
Thank you, everyone.
Thank you so much.